Welcome back to Module 4, Part 2 of Assessment of the Nervous System. So I wanted to, while you guys are reviewing this information that is found in your chapter 41, I wanted to reinforce a core measure. Core measures are very important. Hospitals need to meet the core measures. So I just want to read this verbatim from the back. It says, determining functional status. For example, a combination of cognition, mobility, and sensory perception is a recommended core measure for patients with complex chronic conditions. Now, we're going to talk about, or I'm going to talk to you a little about the older adult and the changes. So they do have sensory changes. They do have cognitive function changes. They have decline in cognitive function. They even have memory problems. So, and their circadian cycle sometimes is off. In addition to that, they have mental status changes. So let's go back and talk about some sensory changes. So with the older adult dealing with sensory, their pupils, the size is smaller. So adjusting to the light is a little bit more difficult than you or I. So that's why when we do teaching, we want to make sure that the room is well lit, or not bright in the middle of the night, but they have those little night light, a soft light to help guide their path. So when they do get up in the middle of the night, they have a pathway and they don't have to worry about bumping into things. Also, their touch, their sensation, it decreases also. So you wonder if the touch decreases, what about that feeling? That sensation. Maybe when they're walking, they don't feel like they're stepping. They don't feel it that they're stepping on small objects. And even that vibration, it's a vibration sense. It's lost in the ankles and feet. So therefore, these patients are at risk for falls. With the cognitive function, sometimes with the memory and everything, sometimes the cognitive function, it decreased because of a chronic condition the patients are having. Sometimes when the cognitive level declines, it can be from either like a drug reaction, some type of toxicity, or even by, as we learned in the earlier lectures, hypoxia. So when the cognitive function decline, we just have to be a little patient. Give the older adult time to learn new information. They can learn it. You just have to be patient and give them time. Also, with your assessment, you will notice that the older adult, they can remember long-term. Their long-term memory is intact. It's much better than the recent information. So with that being said, you might have to repeat some things when you do your teaching for the long-term, for your older adult. And also just have them state it back to you to make sure that they understand. These are subtle memory changes that's occurring. And sometimes those subtle memory changes are caused by like loss of cerebral neurons, which is associated with the aging process. Now, when we talk about sleep, their circadian responses are reduced. So a lot of times their sleep-wake cycle is less responsive to stimuli and signal patterns of sleep. So what I'm trying to say is a lot of the older adults, they go to sleep earlier in the morning, but they wake up very early. Sometimes in the middle of the night, they stay awake for about periods of 30 minutes. And then sometimes, like any noise can stimulate them and they awaken very easily. So I don't want anyone to think that the older adult doesn't need sleep. They need as much sleep as the younger adult needs. But you will find that the older adult will take naps during the day. Now, some of the older adults are experiencing mental status changes. So we have to make sure that we understand that sometimes some of these changes are due to infection, hypoxia, hypoglycemia, hyperglycemia. So as a nurse, we know that. We're going to do critical thinking. So when we notice some confusion is happening, we're going to check our O2 set on our patients. We're going to check the blood glucose levels, right? We're also going to even check for any possible infections with the urine. So you would notify the doctor and get a urine specimen from the patient, checking the patient vital signs, making sure they don't have a fever or any wounds or anything like that that could possibly signify that the patient is having signs and symptoms of an infection. Okay, so just noted this. I think I said this to you guys once before, but often decrease or change in mental status, like acute confusion. All of a sudden your patient was fine and then at night they became confused, or during the day they became confused. It's a key early sign of infections process in older patients, such as a urinary tract infection. A lot of nurses always, we want to check the urine once our patients are having acute changes and become confused. Okay, so with our neuro assessment, which is found in chapter 41, and I am speaking about the medical surgical nursing book, IGGY, 9th edition, we want to make sure that we get our patient history, okay? So make sure we obtain the history from the patient or maybe a family member, caregiver, who's really helpful with the information. And we want to make sure if there's any, if there are any medications, get their history, including smoking, any drug abuse, even their occupation and their current lifestyle. Make sure you also ask about any medical history, like any history of congestive heart failure, any health problems at all, any history of stroke. Make sure you know about their activities of daily living so we will know what level they are at and we can establish a baseline for them. Ask whether the patient is right-handed or left-handed. A lot of times we forget about that in our neuro assessment. Are you right or left-handed? Then we can know which side is the stronger or the dominant side when we're assessing the patient. Ask the family about history, such as if they had a history of a stroke, including with those chronic conditions. Ask about any chronic conditions if they may have those. So your physical assessment, I know that this is beginning med surg, but I want us to try our best to complete a neurological assessment, a complete one, not a focused one. So I want us to get used to including that patient history, evaluation of their mental status, making sure you're aware of their cranial nerves, if they have any deficit, we went over those earlier, mobility and motor system function, deep tendon reflexes, their sensory perception, and the cerebellar function also. Make sure in your assessment you're looking for asymmetry, such as septal unequal movements in the facial muscles. Very important. Make sure that we know those so we can notify the physician, because when we do our assessment, it kind of tells us like where the lesion or the injury in the central nervous system is. The assessment can further help healthcare providers determine if abnormalities are in the cortex, below the cortex, or multifocal. Now next, I'm just going to go through some slides. We've been doing this already. We kind of jumped the loop in the very beginning of fundamentals, but I just want to show you these slides, and I'm not going to really say much on them, but I just want to make sure that you are aware of the, the slides. I'll talk about pupils. One second. Here's more of our neuro assessment. Now you're looking at the pupils, you're checking the size of the pupils, also the eye movement, or 6 cardinal gazes. And now I want to talk to you about your cerebral motor function. And this is something we haven't talked about much, but I want to talk about it. So look at each picture and look how the body is. This is a decorticate posturing. Problems that's happening in the brain, and I'll go over that. But I want you to look at the arms, how they're flexed over. Okay, remember flexion and extension, but she's flexed over. Look at everything that's going on here. Okay, now decerebrate posturing. Look at the arms here. Okay, look at the extension. Look how it's different. So to the body, and it's going away from the body. Take your time and read each of these paragraphs concerning decorticate and decerebrate. Decortication is an abnormal motor movement seen in the patient with lesions that interrupt the cortical spinal pathways. So I might be reading what you're saying here, but I wanted to reinforce that the patient's arms, wrists, and fingers are flexed with internal rotation and plantar flexion of the legs. Now, when you're talking about decerebrate, that is abnormal movement with rigidity. It's characterized by extension of the arms and legs, pronation of the arms, plantar flexion, and when the body spasms, which the body is bowed forward. It's called opisthotonus. I would like to add on page 848 in your med search book, chapter 41, Bambisky sign. It's a dorsiflexion of the great toe and fanning of other toes. It's abnormal in anyone older than 2 years and represents the presence of central nervous system disease. The term positive Bambisky sign, that's abnormal response, and you might hear some say negative Bambisky sign, normal response. Now, as you assess your motor strength, I want you to also gear towards page 848 where it speaks about assessment of the motor function. So I want to make sure that when you're assessing your patients, you observe your patient for involuntary tremors or movements. So not only are you assessing the motor function, but you're using your critical thinking skills to say, you know what, maybe this patient might have something else going on. Maybe it might be multiple sclerosis and I need to let the doctor know. Or maybe the patient is on some type of psychotropic drugs. So while we're checking the strength, you're also checking movements and tremors, things as such, so we can identify problems early and notify the physician. So make sure that you assess the patient for motor movement that indicates maybe irritability, hyperactivity, or slowed movement. So note those things, okay? Measure the patient's hand strength. You know how what you guys are doing now by asking the patient to do to squeeze your hands, or you can also you can compare. So remember, in all your assessments, you compare one side to the other. You can also have them, he or she, grab your finger, and then to see if they're following commands, then you can ask them to release your fingers so you can get your fingers out of there. But you're trying to pull your finger and see how strong they're holding on to it. Okay, there is a 5-point rating scale, and you guys see that here. Always evaluate and compare strength on each side. So make sure you always compare from one side to the other. Remember, the cerebral motor or brainstem integrity may be assessed. So ask the patient to close his or her eyes and hold the arms perpendicular to the body with, with the palms up for 15 to 30 seconds. And that's part of your assessment that you're doing every day with your patients when you go in and do your assessment. Okay. If there is a cerebral or brainstem reason for muscle weakness, the arm on the weak side will start to fall. So we can do that also by asking the patient to hold their legs up, and we do a countdown. Sometimes we count down 15 seconds, sometimes it's 10 seconds, depending on the neurological assessment scale that you're doing, to see if the patient is able to hold that. If not, we give them a certain point in our detailed neurological assessment. And we can also state that the patient is drifting, D-R-I-F-T. So they may have a it's called a pronator drift. So once we ask, they can't keep their arms up and you see it starting to fall, or it just falls, we just have to document what we see and document it correctly. Now, our next couple of slides, we're going to go over some terms. So I want to make sure you pay attention to these terms. The slides are going to be moving fast, but you can always pause, come to class with questions if you have any. So we have aphasia. Then we also talk about the motor and expressive. Remember, it's also known as the Broca's damage. So you have to remember those areas of the brain that I showed you earlier. Here's more dysphagia with the G. Some of these terms you already know. Dysarthria, slurred speech, alexia. You're gonna see this a lot in stroke patients. Inability to understand written language. It's get very frustrating. Anomia, inability to find words. These are very frustrating for the patient. More here, and I'm just gonna go through these terms really fast, and I'm going to stop there, and we're going to have a part 3. This is part 2, so we're going to have part 3, and we're going to talk about cerebral vascular accidents. Thank you for listening. So this is module 4, part 2, and stay tuned for part 3. Thank you. Please read chapter 41, diagnostic assessment. laboratory and imaging assessment, and cerebral